Air leak syndromes occur when gas escapes from the normal confines of the respiratory tract and accumulates in extrapulmonary spaces. The common pathway is alveolar rupture, usually from overdistension or uneven pressure distribution, allowing air to dissect along perivascular or peribronchial sheaths. This process can result in several distinct entities: pneumothorax, where air collects in the pleural space; pulmonary interstitial emphysema, where air tracks within the interstitium; pneumomediastinum, when gas accumulates around the mediastinum; and less commonly, subcutaneous emphysema or pneumopericardium. Each has different clinical implications, but all reflect a failure of the fragile neonatal lung to tolerate pressure or volume stress. Recognition is essential, because while some air leaks resolve spontaneously, others rapidly compromise ventilation, perfusion, or hemodynamics, and require urgent intervention. The initiating event is rupture of fragile alveoli. In premature infants, this occurs because of structural immaturity and poor surfactant, which raise the pressures required to inflate the lung. In term infants, meconium aspiration, pneumonia, or vigorous resuscitation can cause uneven inflation and overdistension. When alveoli rupture, air escapes into the perivascular and peribronchial interstitium. From there, it can track along tissue planes. If it reaches the pleural space, pneumothorax develops. If it remains in the interstitium, pulmonary interstitial emphysema occurs. Air that dissects centrally may enter the mediastinum, and from there can extend to the pericardium or subcutaneous tissues. The physiologic consequences depend on the site. Pleural air impairs lung expansion, interstitial air compresses surrounding alveoli and vessels, and mediastinal air can compromise venous return. The unifying principle is that positive pressure, whether intrinsic or applied, drives gas into spaces where it does not belong, creating both mechanical and hemodynamic compromise. Several conditions predispose neonates to air leak syndromes. Prematurity is a major factor because immature lungs have poor compliance and require higher pressures for ventilation, making rupture more likely. Respiratory distress syndrome carries the same risk, as stiff alveoli collapse and reopen repeatedly, generating shear forces. Positive pressure ventilation, especially with high peak pressures or volumes, is a leading iatrogenic cause. Meconium aspiration produces ball valve obstruction, creating localized air trapping and overdistension. Pneumonia and transient tachypnea of the newborn both impair fluid clearance and cause uneven inflation, predisposing to rupture under pressure. Pulmonary hypoplasia is vulnerable because the small number of alveoli must accept the full volume of each breath, increasing stress per unit area. Finally, spontaneous air leaks can occur in otherwise healthy term infants, often after vigorous crying or delivery room resuscitation. Recognizing these risk factors helps anticipate air leak development and guides preventive strategies, such as gentle ventilation and early surfactant use. Pneumothorax occurs when alveolar rupture allows air to escape into the pleural space. Each breath increases the volume of trapped pleural air, progressively compressing the underlying lung and shifting the mediastinum. This reduces ipsilateral lung expansion and impairs venous return by increasing intrathoracic pressure. In a tension pneumothorax, these effects become hemodynamically significant, causing hypotension, bradycardia, and even cardiovascular collapse. The underlying driver is excessive alveolar pressure, whether from intrinsic disease, such as meconium aspiration and pneumonia, or from positive pressure ventilation. Clinically, pneumothorax highlights the vulnerability of the neonatal lung. Even modest overdistension can rupture fragile alveoli. And because the pleural space is small, even a small volume of air can produce dramatic compromise. Presentation varies with the size and rate of air accumulation. Small leaks may be asymptomatic and discovered only on routine chest X-ray. Moderate pneumothoraces present with sudden increases in oxygen requirement, tachypnea, or retractions as the compressed lung loses functional capacity. Large or tension pneumothoraces produce acute decompensation, severe hypoxemia, asymmetric chest movement, diminished or absent breath sounds on the affected side, and hyperresonance to percussion. The mediastinum may shift away from the affected side, compressing the contralateral lung and great vessels. Cardiovascular signs include tachycardia, followed by bradycardia and hypotension as venous return falls. Cyanosis and apnea can rapidly follow if untreated. Clinically, the abrupt onset and asymmetry of findings distinguish pneumothorax from diffuse processes such as RDS or pneumonia. Diagnosis is based on both clinical suspicion and imaging. A sudden increase in oxygen or ventilator requirement, combined with asymmetric chest movement and diminished breath sounds, should raise immediate concern. Transillumination with a high-intensity light source can provide a rapid bedside clue. The affected hemithorax will appear brighter as air conducts light. Chest X-ray remains the standard diagnostic tool. Findings include a visible pleural line with absent vascular markings beyond it, lung collapse with mediastinal shift in tension cases, and occasionally subcutaneous emphysema. Point-of-care ultrasound is increasingly used and can detect pneumothorax with high sensitivity. The absence of lung sliding and the presence of a barcode sign on M mode confirm the diagnosis. The critical teaching point is that diagnosis should never be delayed for imaging when tension physiology is present. Clinical signs alone justify immediate decompression. Management depends on the size of the leak and the infant's stability. Small asymptomatic pneumothoraces may be observed with close monitoring and supplemental oxygen, as nitrogen washout can accelerate resorption of pleural air. Symptomatic or enlarging pneumothoraces require intervention. Needle aspiration provides immediate decompression in unstable infants. The procedure is performed at the second intercostal space in the midclavicular line or the fourth to fifth intercostal space in the anterior axillary line using a needle attached to a syringe and three-way stopcock. For ongoing air leaks or tension physiology, chest tube placement is required. The tube is connected to an underwater seal or suction system to provide continuous evacuation. Throughout management, ventilator pressures must be minimized to reduce ongoing air escape, and high-frequency ventilation may be considered if conventional settings cannot prevent further injury. The overarching principle is prompt recognition and stabilization to prevent hypoxemia and cardiovascular collapse. Pulmonary interstitial emphysema develops when air escapes from ruptured alveoli and dissects into the perivascular and interstitial tissues instead of the pleural space. This air tracks along connective tissue planes, compressing adjacent alveoli and small vessels. The result is reduced compliance, impaired gas exchange, and ventilation perfusion mismatch. The condition is strongly associated with mechanical ventilation in very preterm infants, where high peak pressures or volumes are required to inflate stiff, surfactant-deficient lungs. Unlike pneumothorax, which collects in a single space, PIE is diffuse and often bilateral, producing a characteristic bubbly or streaky appearance on imaging. Physiologically, the trapped interstitial air acts as a splint that prevents adjacent alveoli from expanding, perpetuating hypoxemia and hypercapnia even when ventilator settings are escalated. This pathophysiology explains why PIE is one of the most challenging air leak syndromes to manage, and why prevention through gentle ventilation strategies is emphasized. Pulmonary interstitial emphysema, or PIE, occurs primarily in premature infants with immature, surfactant-deficient lungs. Its epidemiology parallels severe respiratory distress syndrome, where fragile alveoli are exposed to high transpulmonary pressures during positive pressure ventilation. The highest risk is in extremely low birth weight infants, especially those less than 28 weeks of gestation, because their alveoli are structurally weak and highly compliant. Term and late preterm infants may also develop PIE, but almost always in the setting of high mean airway pressures, vigorous resuscitation, or meconium aspiration. Mechanical ventilation is the strongest modifiable risk factor. High peak pressures, long inspiratory times, and poor synchrony increase alveolar rupture. Excessive continuous positive airway pressure can also contribute. Surfactant deficiency amplifies the risk, since uneven aeration produces areas of collapse adjacent to overdistended regions, generating shear stress and rupture. Pulmonary interstitial emphysema, or PIE, occurs primarily in premature infants with immature, surfactant-deficient lungs. Its epidemiology parallels severe respiratory distress syndrome, where fragile alveoli are exposed to high transpulmonary pressures during positive pressure ventilation. The highest risk is in extremely low birth weight infants, especially those less than 28 weeks of gestation, because their alveoli are structurally weak and highly compliant. Term and late preterm infants may also develop PIE, but almost always in the setting of high mean airway pressures, vigorous resuscitation, or meconium aspiration. Mechanical ventilation is the strongest modifiable risk factor. High peak pressures, long inspiratory times, and poor synchrony increase alveolar rupture. Excessive continuous positive airway pressure can also contribute. Surfactant deficiency amplifies the risk, since uneven aeration produces areas of collapse adjacent to overdistended regions, generating shear stress and rupture. Chest radiography is the primary diagnostic tool for pulmonary interstitial emphysema. The characteristic finding is streaky or cyst-like lucencies radiating from the hilum along bronchovascular bundles. This gives the lung a bubbly or irregular texture within the parenchyma, rather than at the pleural edge. Diffuse disease produces bilateral overexpansion with patchy lucencies superimposed on the granular background of respiratory distress syndrome. Focal disease is often unilateral, most frequently in the right upper lobe, and can mimic tension pneumothorax when hyperinflation and mediastinal shift are present. The key distinction is that PIE produces intraparenchymal lucencies, while pneumothorax shows a discrete pleural line with collapse of underlying lung. The persistence and progression of these intrapulmonary lucencies despite modest ventilator adjustments is typical. Computed tomography can delineate the pattern more precisely, but routine diagnosis relies on chest X-ray. Accurate recognition is essential to avoid unnecessary procedures, such as chest tube placement, and to guide timely ventilator strategy adjustments. The cornerstone of pulmonary interstitial emphysema management is modification of ventilatory support to reduce further alveolar rupture. High peak inspiratory pressures, long inspiratory times, and elevated mean airway pressures all worsen air dissection into the interstitium. The goal is to minimize these pressures while still supporting gas exchange. Conventional ventilation can be adjusted by lowering peak pressures, shortening inspiratory time, and accepting higher levels of carbon dioxide within safe limits. This permissive hypercapnia approach reduces shear stress and overdistension. However, conventional strategies are often inadequate once PIE is established. High-frequency ventilation, particularly jet ventilation, is frequently the preferred mode. Its rapid pulses of small tidal volumes maintain ventilation with significantly lower mean airway pressures, limiting additional injury. High-frequency oscillatory ventilation can also be effective, but the continuous distending pressure may exacerbate air leaks in some infants. Choice of modality depends on unit experience and the infant's overall stability. The principle is clear. Ventilation should be tailored to minimize barotrauma and volutrauma. Escalating pressures in the face of worsening compliance only fuels the cycle of PIE progression. Early transition to high-frequency modes offers the best chance to halt that cycle. When ventilator adjustments alone fail to control pulmonary interstitial emphysema, adjunctive strategies may provide benefit, especially in localized disease. Positioning the infant with the affected lung dependent can reduce ventilation to the diseased side. Gravity favors perfusion of that lung, while shifting most ventilation to the opposite lung, permitting partial decompression. This maneuver is most effective in unilateral or lobar PIE and should be monitored closely with serial blood gases and imaging. Selective mainstem intubation is another option for severe unilateral disease. By advancing the endotracheal tube into the main bronchus of the healthier lung, ventilation bypasses the diseased region. This requires meticulous technique, frequent repositioning checks, and careful monitoring to prevent atelectasis or obstruction of the ventilated lung. In cases where localized PIE persists despite conservative measures, more invasive interventions may be considered. These include intentional collapse of the affected lobe, sometimes achieved with artificial pneumothorax, or surgical resection in refractory localized disease. These approaches are rare and reserved for infants with life-threatening, non-resolving PIE. These selective measures highlight the complexity of PIE management. They are temporizing strategies aimed at limiting further damage while providing an opportunity for fragile lung tissue to recover. Pulmonary interstitial emphysema carries significant short and long-term implications. Acutely, it is associated with persistent hypoxemia, hypercarbia, and an increased risk of secondary air leaks such as pneumothorax or pneumomediastinum. Severe cases can precipitate rapid decompensation requiring emergent intervention. Mortality is highest in extremely low birth weight infants who require prolonged high-pressure ventilation. For survivors, PIE often marks the beginning of chronic respiratory morbidity. Interstitial air disrupts alveolar and airway development, increasing the likelihood of bronchopulmonary dysplasia. Children with a history of severe PIE have higher rates of recurrent wheezing, reactive airway disease, and long-term obstructive physiology on pulmonary function testing. The degree of prematurity, underlying surfactant deficiency, and severity of ventilator dependence all contribute to prognosis. Radiographic resolution does not always equate with full recovery. Even after lucencies clear, residual scarring and air trapping can persist. Follow-up in specialized neonatal pulmonary or bronchopulmonary dysplasia clinics is warranted to monitor lung growth, exercise tolerance, and vulnerability to infection. Outcomes therefore reflect both the acute challenge of stabilizing fragile lungs and the chronic sequelae of disrupted development. Recognition of PIE as a high-risk event allows early initiation of strategies to minimize long-term morbidity. Chylothorax is the accumulation of lymphatic fluid in the pleural space, which restricts lung expansion and can impair venous return. In neonates, it develops either from congenital malformations of the lymphatic system or from iatrogenic injury, most often after cardiothoracic surgery or central venous catheter trauma. The effusion contains protein, triglycerides, and lymphocytes, so persistent loss produces nutritional deficits, electrolyte imbalance, and immunosuppression. The fluid typically appears milky after enteral feeds due to chylomicrons, though it may be clear in fasting infants. The growing intrathoracic volume compresses lung tissue and shifts the mediastinum if large. Clinically, infants present with tachypnea, retractions, decreased air entry on the affected side, and dullness to percussion. Hypoxemia develops when lung compression reduces functional residual capacity and worsens ventilation perfusion matching. Diagnosis is confirmed by chest radiograph or ultrasound showing pleural fluid, and by thoracentesis demonstrating a lymphocyte-predominant effusion with elevated triglyceride content. Recognition is important not only for acute stabilization, but also because untreated chylothorax predisposes to prolonged respiratory compromise and recurrent infections. Management of neonatal chylothorax balances three goals: relieve respiratory compromise, limit ongoing child loss, and support nutrition and immunity. Initial stabilization begins with drainage. A chest tube is often required when the effusion is large enough to cause respiratory distress or hemodynamic instability. Controlled evacuation relieves lung compression and improves oxygenation, but excessive rapid drainage should be avoided to prevent circulatory collapse. Nutritional management is central. Because lymph flow increases with long-chain triglyceride absorption, enteral feeds are switched to formulas containing medium-chain triglycerides that bypass lymphatic transport. In more severe cases, infants may require bowel rest with total parenteral nutrition to fully suppress child production until healing occurs. Electrolytes, protein, and immune status should be monitored closely, as persistent losses quickly lead to deficiency. Pharmacologic therapy is sometimes added. Octreotide, a somatostatin analog, reduces splanchnic blood flow and lymphatic output and can be considered in refractory cases. Adjunct measures include meticulous fluid balance, replacement of fat-soluble vitamins, and infection surveillance. Surgical ligation of the thoracic duct or pleurodecies is reserved for infants with ongoing high-volume child loss despite maximal medical therapy. Early multidisciplinary involvement with surgery, nutrition, and neonatology improves outcomes. Chest tube placement in neonates is reserved for situations where simple measures are insufficient. The most common indication is a symptomatic pneumothorax that does not resolve after needle aspiration or that recurs after temporary decompression. Larger recurrent air collections place the infant at constant risk of tension physiology and require a definitive drain. Another clear indication is a ventilated infant with an ongoing air leak. Continuous bubbling of air into the pleural space prevents adequate lung inflation, impairs oxygenation, and makes mechanical ventilation ineffective without a chest tube in place. Pleural effusions are also managed with tube drainage when they are large enough to cause respiratory distress. In neonates, this includes chylothorax, where repeated accumulation of lymphatic fluid not only compresses the lungs, but also leads to nutritional and immunologic compromise if not drained. At the bedside, the key principle is that chest tubes are invasive and should be placed only when observation, oxygen, or needle aspiration are insufficient. Recognizing the clinical thresholds for intervention prevents both undertreatment of life-threatening air leaks and overuse of procedures that carry their own risks. Chest tube insertion in neonates requires precise technique and strict asepsis. Identify the 4th to 5th intercostal space just anterior to the mid-axillary line. Make a small skin incision over the superior border of the lower rib. Bluntly dissect with a curved hemostat while keeping the instrument tip immediately above the rib. The intercostal artery, vein, and nerve run along the inferior border, so entry below the rib risks injury. Advance with controlled pressure until a loss of resistance confirms pleural entry, then open the clamp to create a tract and guide the tube. For air, direct the tract anteriorly and apically. For fluid, direct posteriorly and basally. Insert the tube 2 to 4 centimeters, appropriate to infant size, then remove the clamp and observe for a rush of air or fluid. Avoid trocar-style insertion in neonates. Blunt dissection reduces the risk of lung laceration. Secure the tube with suture and apply an occlusive dressing. Obtain a post-procedure chest radiograph to confirm position and depth, and adjust as needed. Key bedside points: pre-oxygenate, provide analgesia, and when feasible, sedation. Keep the tip above the rib during all passes. Never force the instrument if resistance persists, and reassess breath sounds and ventilation immediately after placement. After insertion, proper drainage setup is critical to ensure the chest tube functions safely. A water seal system is the standard because it prevents air or fluid from flowing back into the pleural space. The system must always be positioned below the infant's chest level so gravity supports drainage and backflow is avoided. There are 2 suction options. Wet suction is controlled by the water level in the suction chamber. Gentle bubbling indicates appropriate negative pressure. Dry suction uses a dial or regulator, providing a visual indicator of function without relying on water evaporation. For neonates, the suction range is lower than in older children, typically -10 to -20 centimeters of water. Air leaks are monitored by bubbling in the water seal chamber, while titling, fluid level movement with respiration, confirms tube patency. Continuous, vigorous bubbling suggests excessive suction or a persistent air leak and should prompt reassessment. Connections must be airtight and well secured with tape, since even a small leak can render the system ineffective. At the bedside, consistent monitoring of the water seal chamber, suction control, and system placement ensures the chest tube provides effective drainage without creating additional complications. Ongoing care of a neonatal chest tube is as important as the procedure itself. All tubing connections must be airtight and reinforced with tape to prevent inadvertent air entry. The drainage system should remain upright and always positioned below the infant's chest level to maintain the water seal. Nurses should routinely assess for bubbling and titling in the water seal chamber. Bubbling indicates an air leak, while titling reflects pressure changes with respiration and confirms patency. Drainage should be evaluated frequently for volume, color, and consistency. Unexpected increases in bloody output may indicate trauma, while a sudden stop in drainage could signal obstruction or kinking. The tube and dressing must be inspected for secure placement and signs of infection at the insertion site. Emergencies require rapid action. If disconnection occurs, the distal end of the tube should be immediately placed into sterile water to recreate a temporary water seal until reconnection or replacement. If the tube is accidentally dislodged, apply a sterile occlusive dressing and monitor closely for tension pneumothorax while notifying the provider. Chest tube care requires constant vigilance. Secure connections, accurate drainage assessment, and immediate response to complications directly impact the infant's stability and recovery. Milking or stripping. Chest tubes is generally discouraged in neonates because the risks outweigh potential benefits. Forceful manipulation generates sudden, excessive negative pressure within the system. This can traumatize fragile lung tissue, promote re-expansion pulmonary edema, or worsen existing air leaks. In a population already vulnerable to barotrauma and volutrauma, avoiding unnecessary fluctuations in intrathoracic pressure is critical. If a clot or obstruction is suspected, best practice is to use the least disruptive method. Gentle milking of the tube may be performed only under provider order and with great caution. Preferable alternatives include carefully repositioning the tube to relieve kinking or using sterile flushing if specifically ordered. Any intervention should be followed by reassessment of bubbling, titling, and chest radiograph if drainage remains inadequate. For routine care, prevention of obstruction is the safest strategy. Secure all connections, minimize dependent loops in the tubing, and maintain the system below chest level. Observation and proactive system management are the most effective safeguards against complications without subjecting the infant to unnecessary pressure swings. Chest tubes should be removed once the air leak or fluid collection has resolved and stability is confirmed. Indications include the absence of bubbling for 24 to 48 hours, a chest radiograph showing lung re-expansion without reaccumulation, and stable clinical status. Removal must be performed with preparation and precision. Adequate analgesia should be given, which may include systemic medication with or without topical anesthesia. After removing securing sutures and dressing, the tube is withdrawn in a smooth motion while applying a sterile petroleum-based occlusive gauze to the site. This prevents air from being sucked back into the pleural space during inspiration. The site is then covered with an airtight dressing and secured. Close monitoring is essential after removal. Watch for recurrent respiratory distress, new desaturation, or asymmetry in chest movement. Repeat chest imaging may be warranted to confirm that the lung remains expanded. Bedside staff should be ready to intervene quickly if recurrence occurs, particularly in infants who remain ventilated or require high mean airway pressures. Safe removal depends on both meeting clear criteria and ensuring vigilant observation in the immediate post-removal period. Chest tube placement in neonates is life-saving but carries important risks. Infectious complications include cellulitis at the insertion site and empyema from contamination of the pleural space. Strict asepsis and ongoing site assessment reduce these risks. Traumatic complications arise from malposition or aggressive insertion. These include lung laceration, diaphragmatic or liver injury, and vascular perforation. Choosing the correct site, dissecting above the rib, and advancing under control are essential preventive steps. Neurologic complications, though less common, are particularly concerning. Phrenic nerve palsy can lead to diaphragmatic paralysis and respiratory insufficiency, while Horner's syndrome may result from sympathetic chain injury. These outcomes underscore the need for precise placement and minimal tissue disruption. Other recognized problems include hemorrhage, iatrogenic chylothorax if the thoracic duct is injured, persistent subcutaneous emphysema, and disturbances in fluid or electrolyte balance when drainage volumes are large. Each complication reflects a balance between necessity and risk. Careful technique, vigilant monitoring, and timely recognition of adverse events help ensure chest tubes provide benefit while minimizing harm. Needle aspiration is a rapid, temporizing procedure for suspected or confirmed tension pneumothorax in a neonate. The indication is clinical deterioration with signs of obstructive physiology, severe respiratory distress, hypoxemia, bradycardia, asymmetric chest expansion, markedly decreased or absent breath sounds on the affected side, and hypotension from impaired venous return. Immediate decompression is required to restore ventilation and circulation. Two common entry sites are used. The first is the second intercostal space at the midclavicular line in the supine infant. The alternative is the fourth or fifth intercostal space at the mid-axillary line with the affected side positioned upward. In both approaches, the needle must be inserted just above the rib margin to avoid the intercostal artery, vein, and nerve that course along the inferior border. This landmark-based approach permits rapid entry into the pleural space, release of trapped air, and stabilization until a definitive chest tube can be placed. Success depends on correct recognition of tension physiology and immediate action at the bedside. Needle aspiration requires equipment that allows rapid, controlled decompression. Commonly used devices include a 20 to 24 gauge angiocath or a 23 gauge butterfly needle, chosen based on the infant's gestational age and weight. A 30 milliliter syringe is connected directly or via a three-way stopcock and extension tubing to allow safe air evacuation. Sterile antiseptic preparation and gauze are required to maintain asepsis during the procedure. The procedure begins with identification of the landmark and preparation of the skin. The needle is advanced just above the rib margin into the pleural space. Once air is aspirated, the needle is withdrawn while the catheter remains in place. The catheter may be connected to the syringe, a stopcock, or an underwater seal to allow continued escape of trapped air. Securing the catheter and monitoring the infant for immediate improvement in oxygenation, heart rate, and chest expansion are critical. Needle aspiration is considered a temporary measure. Definitive management with a chest tube is required for persistent air leaks. Continuous monitoring of oxygen saturation, perfusion, and respiratory effort is essential during and after the procedure. Outcomes for neonatal air leak syndromes vary depending on the type, severity, and underlying lung disease. Pneumothorax, when recognized and drained appropriately, usually resolves without long-term sequelae, although recurrence is possible, especially in ventilated infants. Pulmonary interstitial emphysema carries a higher risk. PIE itself is a major contributor to bronchopulmonary dysplasia, particularly in extremely low birth weight infants. Chronic lung disease, prolonged mechanical ventilation, and impaired alveolar development are common sequelae. The severity of PIE correlates with the extent of lung involvement and the pressures required for ventilation. Chylothorax generally resolves with supportive management, drainage, and nutritional optimization, but persistent cases can impair growth, immunity, and overall clinical stability. Early recognition and careful management are essential to minimize complications. Across all air leak syndromes, gestational age and the degree of prematurity strongly influence prognosis. Infants with more immature lungs are at higher risk for prolonged ventilation, chronic lung disease, and neurodevelopmental impairment. These outcomes underscore the importance of preventive strategies, gentle ventilation, and early intervention at the bedside. Several high-yield points guide the bedside management of neonatal air leak syndromes. Pneumothorax should be suspected in any infant with sudden deterioration, particularly if transillumination of the chest reveals a bright glow over a hemithorax. Immediate recognition and intervention prevent progression to tension physiology. Chest tubes must never be clamped in a neonate with an ongoing air leak, as this can precipitate tension pneumothorax. Proper insertion, positioning, and monitoring are essential to avoid trauma and maintain function. Pulmonary interstitial emphysema presents radiographically as bubbly, linear lucencies radiating from the hilum, contrasting with uniform air bronchograms seen in respiratory distress syndrome. Recognition of these patterns informs ventilator adjustments and preventive strategies. High oxygen strategies, including nitrogen washout, are no longer recommended due to lack of demonstrated benefit and potential harm. Chylothorax is identified by a milky pleural effusion with elevated triglycerides and is commonly seen following cardiac surgery. Management focuses on drainage, nutritional support, and minimizing ongoing lymphatic loss. Attention to these details improves recognition, intervention, and long-term outcomes across all neonatal air leak syndromes.